Okay, good afternoon, everyone. Today's my topic is antithrombotic therapy of acute coronary syndrome based on etiology. The first part is about the pathology of plaque rupture and plaque erosion. We all know from the biopsy the reasons for acute coronary syndrome include plaque rupture accounts for 60 to 75%, and plaque erosion accounts for 30 to 35%. And these two reasons are the main two reasons for acute coronary syndrome. And just the other reason, just like calcified nodule, accounts for 2 to 7%. But we know that the two main reasons, plaque rupture and plaque erosion, very different in pathology. And the plaque rupture with the very thin fibrous cap thickness and the big lipid core and the huge macrophage infiltration. But for plaque erosion is the thick fibrous cap thickness and the small lipid core and without or less macrophage infiltration. But these two very different pathologic reasons for acute coronary syndrome in clinic by angiography, we can only see the stenosis of coronary artery, but we can't classify as plaque rupture or plaque erosion. So in clinic, most of the ACS patients will be given stent implantation. And so just until the use in clinic optical coherence tomography, we know that OCT have a higher resolution for 10 micrometers and is highly consistent with pathology and was known as optical biopsy. And so it's possible for us to use OCT in clinic to diagnose and treatment, process diagnosis and treatment for acute coronary syndrome. So just by my teachers, Professor Yubo in our team, we first used OCT 2013 and established imaging diagnostic criteria for acute coronary syndrome etiology, including plaque rupture, plaque erosion, and the other very just tight stenosis, dissection, hematoma, coronary spasm, the criteria. And mainly we pay attention to the two main reasons for ACS. Plaque erosion is just intact fibrous cap with thrombus, but we can see irregular of the lumen just area. And the plaque rupture, you can see disrupted fibrous cap with the cavity, and the base of the plaque is the lipid plaque with or without thrombus. You can see very typical OCT imagings for plaque rupture and plaque erosion. This is you can see the disruption of the fibrous cap and ruptured cavity. This is plaque rupture. And for plaque erosion, we just classified into two categories. The first is definite one, the second is probable one. For definite one, you can see thrombus here is the white thrombus, but the underlying plaque structure can be visualized. It's intact one. You can't see the disruption of the fibrous cap. But for probable one, maybe you can't see the thrombus, but you can see a regular lumen surface, or you can see the thrombus, but you can't see the plaque structure, but you can't classify the superficial lipid or calcium plaque, just the proximal or distal to the lesion. So we use OCT observed serious patients. We found that plaque erosion accounts for 31% of the ACS patient. And we also found that the clinical characteristics for plaque rupture and plaque erosion are very different. You can see that plaque erosion patients is just much more younger, and you can see that lumen stenosis is smaller than plaque rupture. You can see average for plaque erosion is accounts for 55.4% stenosis, but for plaque rupture is near 70%. And the most important for plaque rupture and plaque erosion is have different type of thrombi. And you can see that plaque erosion, most of them is the white thrombi, and so the volume is smaller. But for plaque rupture, it's difficult. It's most of them is red thrombi, and so the volume is bigger. And so the criteria for how to classify plaque rupture and plaque erosion was written in 6 international textbook. And the second part is about antithrombotic treatment of acute coronary syndrome, because most of just in clinic for emergency PCI for ACS treatment is stent implantation. But the question is, if we don't do stent implantation, antithrombotic treatment therapy for ACS is safe or not, or effective or not. And so just the idea beginning is about some observational clinical study in our center. And we observed that if for plaque erosion after the treatment, and you can see that plaque erosion is the residual thrombus is small, and most of them is the white thrombus. But for plaque rupture is 3 times bigger volume of thrombi than plaque erosion, and most of them is the red thrombus. But if we give the different type, the reason of ACS patient, plaque erosion and plaque rupture, to give the stent implantation, and we observed that the plaque erosion have the poor delayed intimal healing than plaque rupture. You can see that is plaque erosion delayed stent healing is 3.4 times more than plaque rupture. And so we can know that they have the plaque erosion and plaque rupture has different therapeutic effect for ACS with different plaque pathologic features. And so beginning from the idea, we just designed a series of erosion study. Erosion study is just a pilot study. Erosion 2 is a prospective observational study. And Erosion 3 is the RCT study. It's just one by one to justify to make sure our idea about the antithrombotic treatment of ACS. Erosion study is a prospective pilot study published in late breaking trial hotline at ESC 2016. If effective antithrombotic therapy without studying intravascular OCT-based management in plaque erosion. And this study, we selected 192 patients, and you can see that from the flow chart, OCT defend is definite erosion, and the angiostenosis less than 70% stenosis was enrolled, and without stenting is only gave the DAPT treatment. And you can see from OCT examination, just 1 month, and thrombus volume decreased 94.2%, and the lumen diameter increased 13.6%. And so just for 1 year follow-up, you can see that only 3 cases revascularization, but no cardiac death and reinfarction. And so just 4 years, and it's very interesting. You can see that without stent implantation, only antithrombotic treatment, the 4 years result, 80% of the plaque erosion ACS patient is continuous stable, needn't just stent implantation. Only 1/5. 20% of patients just diagnosis is just become more serious and give the stent implantation. We just the 2-part group, we make some comparison, and we see that if after the thrombotic treatment, and only 45.5% of the risk diagnosis patients need stent implantation to reach the primary endpoint of thrombus volume decrease more than 15% at 1 month. And so you can see that it's very important antithrombotic effect for this patient. if has a good result of the volume, thrombus volume decrease, it can keep the stable for such kind of patient. A recent study was published as the cover article in European Heart Journal, and Professor Peter Libby gave the comments. The result of erosion study will change the treatment strategy of many acute coronary syndrome patients and break the current one-size-fits-all interventional treatment strategy. And not all ACS patients need stent implantation. So based on erosion study, we continue the Asian 2 study. Asian 2 study, the idea is about, in addition to plaque erosion, if some part of the plaque rupture, patients can treat with the antithrombotic therapy and needn't stent implantation. And so you can select partly plaque rupture patient. If the plaque rupture is a low risk one and with a bigger lumen area and not the flow limiting plaque rupture, and the low risk one, you can see that the thrombus burden reduced more than 50% is similar for plaque erosion and low risk plaque rupture. This is a multi-center prospective observational study. So Asian 2 study tell us that partly plaque rupture with the low-risk pathologic factors can also be treated conservatively with antithrombotic therapy. And you can see that this is some part of low-risk plaque rupture patient. Just give the DAPT treatment 1 year, thrombus volume decreased near 98%, and the lumen diameter increased 3.7%. So it has really a good result. But we must know the idea is just the low risk plaque rupture, not all the plaque rupture. And so just for this patient, you can see that is 71 years old, diagnosed as acute myocardial infarction. You can see correlation is along the middle of the RCA, very tight, severe stenosis. But after the thrombus aspiration, and you can see just the stenosis is much less. And so we use OCT to observe here. You can see the plaque rupture and a bigger cavity. But you know that this area is big enough, and so we didn't give stent implantation. And you can see after 1 year, the plaque rupture healing fully, and so it just lumen diameter increased. So the 1 year follow up is safe and effective, and the patient needn't stent implantation. So Asian 3 study is just a prospective randomized controlled multi-center clinical trial. It just the idea is about for STEMI patients when give the angio and the thrombus aspiration, if reach result about TIMI flow grade 3 and diameter stenosis less than 70% is just randomed into 2 groups. One group is OCT guided, and the second is angio guided. OCT guided group is just plaque erosion scared or plaque rupture without dissection and needn't stent implantation. Angio guided is judged by the operator, and so the primary endpoint is the rate of stent implantation during primary PCI. Second endpoint is the MACE with 1 month and 1 year. You can know just the primary endpoint by OCT guidance, and is much more 15% reduction of stent implantation than angio guided. And so for 1 month and 1 year, you have good safety endpoint. And just at beginning, and just you know that 86% of plaque erosion and 41% of plaque rupture, low risk one, needn't stent implantation. You can see this is plaque rupture case, and this is plaque erosion case, all have the good result at the follow-up. So just for from Asian study to Asian 2 and Asian 3 told us that not all the ACS patients is the same, and we can know that correlation with the thrombi. But if the basis, the reasons etiology is plaque rupture or erosion is very different. Plaque rupture is just with red thrombi and erosion is white thrombi. So if after the thrombus aspiration, we use OCT or other imaging modality to determine the reasons is plaque erosion or plaque rupture, include plaque rupture into the high risk one or low risk one, and we can judge is no stenting therapy or with the anti-thrombotic therapy, or if the need the stent and to get a good result by intravascular imaging guidance. And so this is series of erosion study tell the clinic the experience. And so in summary, I think like the anti-thrombotic treatment therapy for ACS is based on intravascular imaging study. Plaque rupture and plaque erosion are important pathologic mechanism of the acute coronary syndrome as the two main reasons for ACS. And the in vivo identification of the pathologic etiology of ACS can guide the treatment of the decision. And like if just a bigger lumen area and plaque erosion and the low risk plaque rupture can avoid stent implantation or delayed stent placement only with the anti-thrombotic therapy. And we should all know that thrombus is the root cause of ACS, and anti-thrombotic therapy is the cause of ACS treatment. That's all. Thank you.